I'm Grace Swee, the director for the Center for Christian Bioethics, and I'm delighted to host this clinical ethics grand rounds in conjunction with the Department of Internal Medicine and the Center for Whole Person Care. So thank you, Dr. Hans, for working with us from internal medicine, and Dr. Barcelo with the Center for Whole Person Care. Again, it's been just a pleasure and a joy to be able to collaborate on a program that is an important, such as this one. I will admit that I've had a roundabout journey with providing spiritual care for patients in my practice. And I think some of the hesitation that I have personally experienced in the past has been related to my personal spiritual journey, but also being unsure of interactions with our chaplaincy department, and also being unsure of how to be able to provide spiritual care in a way that is meaningful and helpful to our patients. I know each one of you here are very intentional about providing the best care for your patients. We are working here at Loma Linda, whose mission is to advance the teaching and healing ministry of Jesus Christ. And ministry, this idea of ministry is really what we want to explore here. So just a quick timeline about our time together. Dr. Saul Barcelo will be giving us a brief presentation on the tools of spiritual care and introducing some ideas about spiritual care. And then we are going to actually have a case-based discussion. So case one is a pediatric case. And we will break you out into breakout groups so you can discuss the questions and the cases, and we'll bring all of us back together. And when we come back together, we'll be discussing the case not only with a clinician, Dr. Merrick Lopez, but also a pediatric chaplain, Asa Nemoto. For case two, it'll be very similar. We'll break out into groups again to discuss it, and then come back to talk about this case together. And our clinician who's going to be helping us with case two is Dr. Joshua Jordan, and our chaplain will be Derek Glatz, who's one of our ICU chaplains. Dr. Barcelo and I will be along for the ride, and we'll be moderating the discussion and also wanting to make sure that our panelists are taking into account your questions. And so if you have questions, please feel free to put it in the chat, and we will be introducing the questions to our panelists within our group discussion together. Again, thank you so much for joining, and without further ado, I want to turn it over to Dr. Saul Barcelo. Thank you, Dr. Barcelo. So glad that you can be with us today.
Thank you. I'm honored that I can come back a second time and hang out for a few minutes with you. Allow me to share my screen. And I want to maybe do a quick review of something we discussed in October. I don't want to assume you were paying attention or you were even there, but nevertheless, you remember we did a poll everywhere where we asked a few questions. One of the questions that I asked you was, how frequently do you encounter aspects of spirituality / religion playing a role in your medical practice? And most of you said, yeah, this is happening, it's relevant, yeah, we see it. We see it on our daily responsibilities here at the hospital. Perhaps you remember that we try to differentiate between spirituality and religion. We try to share some of the definitions that are out there in different literature. And if you remember spirituality, that's really where we kind of decided to focus on, because while many people feel hesitant about identifying with one religious community, most people would say I'm spiritual. So if you remember the definition or the definitions, they kind of gravitated towards anything that gives us meaning and purpose. Another thing that we explored together was the fact that spirituality or spiritual care is not just for specialists, chaplains, but could be for any of us in healthcare. So this is your response. And so perhaps I want to take it to the definition of spiritual care. What is spiritual care? Now, again, there are so many definitions. It will be hard for us to just focus on one. There's one definition that continues to come up in the literature of nursing and medicine and even in chaplaincy. And so I thought, hey, why don't we use this definition, since there's different disciplines who kind of agree that this is spiritual care. Still very vague, still very general, but it's an intervention or interventions, individual or communal, that facilitate the ability to express the integration of the body, mind, and spirit to achieve wholeness. Something we talk a lot here at Loma Linda University Health: wholeness, health, and a sense of connection to self, others, and or higher power, God. What is spiritual care? An intervention. Now, interesting, many of us are passionate about spiritual care, and Dr. Harold Connick from Duke University reminds us that, hey, wait, I know we're passionate about it. Perhaps even without the training, we want to implement it into our own care of patients. But he says healthcare professionals should do nothing in this area, including referral to, specialists, pastoral care, or chaplains, or even interventions such as prayers with patients, or sharing something that gives meaning. He says the spiritual history is something that you must do first, because this is going to set the stage for all future actions in this area and may impact the medical care plan being developed for the patient. A chaplain, author of the book on significant components of spiritual care, from his expertise, advises the same thing, but invites us to also develop skills. It's not just asking the questions, but we must develop some skills so we can interpret whatever we're getting from the patient. He says providing spiritual care requires knowledge of the basic questions of spirituality and an understanding of how to collect data on a person's spiritual history, as well as skills in observing, listening, interpreting, and verifying what would be the best approach in terms of a spiritual intervention. I know when time is short, perhaps those skills are hard to implement. One of our own ethicists, a well-renowned scholar, Dr. Winslow, and his wife, also Dr. Winslow, they published this helpful article titled Ethical Boundaries of Spiritual Care. And at the same time, they share what a physician and also what a chaplain recommended. They said, in order to provide respectful care, healthcare professionals should seek a basic understanding of patients' spiritual needs, resources, and preferences. He says this: just as it would be inappropriate to give physical care without an understanding of a patient's diagnosis and the goal of treatment, it will be inappropriate to proceed with spiritual care that does not take into account the distinctive beliefs and value of the patient. Fascinating article, highly recommended. I think we may make it available. Now, how do we gather this information? There are 3 different ways in which gather this information. Perhaps you remember we talk about spiritual screens that anyone in the hospital can do. 1 or 2 basic questions: religious affiliation, do you want to see a chaplain or not? Most of the times these answers will not help us a lot. People may think chaplain, it's something that you have access when you're dying. Or you know what, I don't know, I haven't practiced my own religious tradition, so why should I identify? So the information, the spiritual screens are not always helpful. So most experts, including those in medicine, will say, let's use the spiritual history tool. A spiritual history is more involved than the screen. Its questions engage the dynamic of the patient's faith or spiritual experience, identifying specific ways in which a patient's religious or spiritual life, both past and present, impact the patient's medical care. In the 1990s, many physicians began to develop their own spiritual history tools. Perhaps one of the first one that was published, it was this one, Spiritual History. Notice 4 or 5 basic questions. It shouldn't take you more than 2 minutes. I know your time is limited, but it still gives you a glimpse of where the patient is coming from. Dr. Harold Koenig from Duke, this was his own that was what was published later on. CSI memo, personally, I think is a little confusing, but you must find something that works for you. This one, perhaps you've seen it in some of the literature published in American College of Physicians and American Society of Internal Medicine. Again, 4 or 5 questions that help us understand where the patient coming from. Again, faith, hope from Brown University School of Medicine. And this one, perhaps the most famous, the most recognized from Dr. Puchalski at George Washington Institute of Spirituality and Health. Again, they're relevant perhaps for their practice. You must find something that works for you. Here at Loma Linda, many of your faculty work on creating their own spiritual history tool named Saul. Again, these are some of the questions that you technically would ask. It shouldn't take you more than 2 minutes. Now, chaplains have also done a little bit of work, and because they have a little more time than you to explore the spiritual life of the patient, they have what we call spiritual assessment tools. Now, the expert in these assessment tools, Dr. George Fitchett, says a spiritual assessment differs significantly from a screen and history. A spiritual assessment is an in-depth look at the patient's spiritual makeup with the goal of identifying potential areas of spiritual concerns and determining an appropriate treatment plan. Again, it's more complex. Some of you may say, I don't have the time. This is another spiritual assessment tool known in the world of chaplains. Some of you who do this recognize. Now, I want to highlight this thing. Just by asking these questions, you are already providing spiritual care. Dr. Harold Koenig says, this sends a message that this aspect of the patient's identity is recognized and respected by healthcare professionals, and that the patient is valued as a whole person. He also says this by doing this, we gather information that is useful for understanding the motivation or lack of motivation behind many of the patients or families' decisions related to healthcare. Third, it provides information about a patient support system and resources within the community that can help ensure compliance with treatment, adequate medical follow-up, and monitoring of the medical conditions. And finally, by just asking these questions, it lets the patient know that this is an area related to health that any healthcare professional is willing to discuss in the future should the need arises. As we transition into the next part of the conversation, I want to remind you that spiritual history or asking these basic questions are really helpful. And Dr. Koenig, again from Duke, says, even if the patient's beliefs are unfamiliar to the healthcare professional, are different from what the healthcare professional believes, or even conflict with the medical, nursing, or rehabilitation care plan, the purpose is to enter into the worldview of the patient in order to understand why the patient believes as he or she does. One last question that we asked you last time we were with you. Who do you believe should address spiritual needs of patients? And I know we could make it a more elaborate, but this is your response. And so you will notice that, physicians, 1/3 of you said, we can do this. We can provide spiritual care. 1/3 of you said, well, it's the role of the chaplains. Well, I know research shows that sometimes we're not working together in this, and this is the reason why we're having this conversation. Again, studies have shown that physicians actually, from all the healthcare professionals, are not the ones who usually recommend seeing a chaplain, following up on aspects of spirituality. And so we want to change that. But also us in spiritual care, as chaplains, we have fallen short. And at times we think this is only our territory. And what Dr. George Hansen proposes is that we collaborate, we come together and explore this for a more of a holistic care. And this is the reason why we're here. And I'm just excited to see how these concepts could be applied, not just on the cases that we'll discuss today, but also in your own medical practice.
Thank you so much for that. I know that for those of you who weren't able to attend the previous presentation, the tools for taking a spiritual history, they sort of flashed by very quickly. So, but have no fear. Our slides will be available after the fact, so you can take a more of a deep dive into the spiritual history. I do want to actually ask Dr. Barcelo, do you mind pulling up the slides again? And we are going to go ahead and transition to our cases. So in order to talk about the cases, I think it's going to be really helpful if you use your phone or some other device to scan the QR code to have access to the cases for discussion. And this will be really handy because what we're going to do after or shortly, Kishali is going to split us all up into breakout groups, and then we'll be discussing these cases in our breakout groups. I wish we could have more time to discuss these cases, but I do think there's a lot of value in bringing us all back together. And so the time that we'll be giving you to discuss in groups is going to be 9 minutes. So that'll leave about 9 minutes for group discussion. And then when we come back together, we are going to be discussing it as a group and also having a clinician, Dr. Merrick Lopez, and then our chaplain, Asa Namoto, in order to help us during this discussion. So while you guys again are scanning the cases for discussion, let me just introduce the first case. Just want to say a special thanks to Dr. Paige Stevens for helping us with this first case. So the first case is about Mary. She's a 17-year-old female. She's been hospitalized in the PICU for quite a long time. She has acute lymphoblastic leukemia, and fortunately, she also has severe encephalopathy due to a rare type of methotrexate-induced neurotoxicity. Her team does not feel like there are any further treatments to reverse this neurological condition, and they have presented to the family that there are two options: to go forward with a tracheostomy and gastrostomy tube placement for continued life-sustaining treatment, or to transition to comfort care and discontinue life-sustaining treatments. Her parents feel like removing Mary from life support would be a sin. Her siblings feel like she's suffering. Her staff, the nursing staff and the clinical staff taking care of her, noticed that the only expression she seems to make is an expression of distress when she is in pain. So the questions that we want you to discuss in your group is based on your knowledge of the family. How would you initiate a conversation about their spiritual needs? Do different members of the family need different kind of spiritual care? What resources would you utilize to help this family cope? Often there can be a discrepancy between between how clinicians feel about the different treatment options. What are some ethical issues that may arise? And the last, based on your clinical background, what reservations might you have in integrating spiritual care in this patient's overall treatment? All right, so I'm hoping again that you have that QR code. Thank you, Kishali, for breaking us up into breakout groups. Just as a show of hands, how many of you thought that you needed to have a bit more time? I'm sorry for the time constraints. Yes, we obviously did not give y'all enough time to join. So while we're gathering back together, I want to introduce our panelists today. First is Dr. Merrick Lopez. He's a pediatric intensivist and chief of our pediatric critical care here at Loma Linda University Children's Hospital. Dr. Lopez is a passionate advocate for spiritual care. And so thank you so much, Dr. Lopez, for joining us. And we also have our chaplain, Asa Namoto, and Dr. Barcelo, would you like to introduce her?
Briefly, I do not want to take time away from the discussion, but Chaplain Asa is a board certified chaplain who works in the Children's Hospital with specific units giving to her and Peds ICU and I believe Peds Oncology. She's one of our excellent alumni from Loma Linda University.
Thank you so much. So welcome to the both of you. So this is the first softball question. What what spiritual needs for the family and for the patient immediately come to your mind? And let's go first with Dr. Lopez, and then we'll go to Chaplain Asa.
Yeah, no, thank you for the opportunity for this. And it's, there's never enough time for these discussions, but I mean, the needs first are definitely to listen to them. And in our group, and in the materials that Dr. Barcelo had, I mean, from any of the models, including the clear model from Loma Linda, it's really like connecting and listening, exploring those kind of things. And often it's just like sitting down, talking to them, and just spending time to let them listen and let them vent. I mean, that's one of the most important aspects in spiritual care is letting somebody feel like they're listened to and trying to understand where they're coming from. So that's first steps for me. That's usually so important to kind of getting to any point where they feel like they're getting the care that's needed.
Thank you. And Chaplain Asa?
Yes, this is a very difficult case, but I work with similar cases. So these situations are happening in the hospital, and then we are there to support everyone. And what the spiritual care looks like can be very, very challenging for all of us. And to even for myself, I feel there's no always absolute answer. But I really appreciated the discussions that I joined today. One of our members expressed that we can start with acknowledging how difficult this is for everyone, and it is the same for us too. And to conveying our care, and then let them know that this is not like easy for us to discuss with you too, and we want to bring the best for Mary too. And also one of our members also shared that we can also invite them to elaborate more what the sin means, the concept of sins. And then I think that is a very important point. It says they have Catholic background, and then it is very helpful information to know. And at the same time, we would like to always remember that we're there to meet with everyone as very unique individual, and that maybe many of you might have already have your own religion, and in each religion there are different denominations, and also even in the same denominations everyone has different belief systems. So it is very important, just like Dr. Lopez mentioned, we carefully listen to them, what they're understanding, what they're conveying to us, and make sure that we hear, and make sure that that they know that they are heard too.
Thank you for that. One question that can come up is how do you, as a clinician, how do you provide spiritual care when you don't agree with the beliefs of either the patient or the family members? So in this instance, say there was, in talking with the family, a very strong belief in a miracle. And how do you integrate spiritual care when you yourself may not believe in the type of miracle that, say, the parents do?
Yeah, no, thank you for that question. And one of our participants in our group, Mark, mentioned, I mean, getting to the bottom of what do they consider a miracle? In many situations, some of the miracles come in ways that they don't, or we don't anticipate are happening. I mean, how many family members are gathered in a place that may not have talked to each other in so long, and those kind of things. And so really just understanding what does that mean for them, and not shutting the door on a potential miracle. Even, we've had cases that seem very impossible, but there's different ways that it manifests. But at that point, it's like, I think helping the kind of grieving process, because either way, whether somebody lives or survives, there may be a part of grieving where they're having to say goodbye to who they thought they were going to be or who their child was going to be. And so often what we do is, one of our colleagues will make space in the bed, no matter how big the kid is, for the families to lay down, hug them, spend some time with them. And, I'll sit down, and I've learned also to say, hey, show me pictures. Tell me about Mary. Show me, what did she like to do? What were her favorite things? How was she? And some of those things kind of help to reconcile. They're like, hey, we're really caring for this for your child here. And then also just sometimes that helps them to cope with like, you know what, this is what she is now is not who she wants to be or who we're used to her being. And sometimes that helps. But I think addressing what they feel is a miracle, I think is important and getting to understand who she was or is to them kind of helps with the start of the grieving process. Sorry, that may not answer different questions, but important in what I see.
Yeah, I love that. And Chaplain Elsa?
Yes, I echo Dr. Lopez. It is, I think, very helpful to hear what miracle means to them. And also one thing that I am learning is miracle can mean something different every day or every moment. So when they are open up and if they are sharing that they're believing miracle, one question that might be helpful that we can ask for them is, I would like to know more about what miracle looks like for you. If that happens right now, what does it look like if that happens right now? And then we can many times I can find the points that I can relate with what they're hoping for their child. And then many times their desire for miracle comes from their love for their child. And then acknowledging their love is very, very important. And sometimes they are feeling that their love is fading, as a parents, when they love their child, when they feel that they cannot save their child, they feel that their love is fading, and then are going through some sense of guilt or some sense of shame as well. So this miracles conversation can be a helpful entrance that go at the beginning of the conversation, what their love means to their child. And then once they really acknowledge that how much they love their children, and also to acknowledge that sometimes we understand all the information, all the medical information in their minds, in their heads, but still our hearts desire for something else. That is totally okay. That is totally natural. And then we can at least pray for what their heart is desiring for, even though in a medical standpoint, what their miracles might look very difficult to see, but we can still pray and bring our hearts before God. And then that is also helpful for the family. And when they really express their desire, sometimes they feel they cannot even say it, or they shouldn't even mention what they really desire for because of their shame or guilt, or maybe they're feeling their faith is weak, and that is why they're going through why they're going through what they're going through. But also if you show your care, and then when they feel safe to open up their heart and really share, this is what we really hope to see, even though this might not happen, but this is what my heart, my love is desiring for for my child. When they can hear it, when we can acknowledge it, it seems like it lifts up their heaviness from their hearts a lot.
I love that. So we're using miracle not as a conversation ender. I am hoping for a miracle, full stop. We're actually using miracle as an invitation, and asking the family to allow us as a medical team to actually journey alongside with them to find out more information about that. Yes, I love that. I really wish we had more time with this case. I think for future programming, we will we will actually assign in much more time. So I just want to thank both of you as our panelists. Thank you so much for sharing with us today. And then what I am going to do now is share my screen and go back to, we have one more case to talk about. And so again, if you need to scan to have access to the cases, this is the QR code. I'm going to leave that up while we talk about our next case here, which is Arthur. and sorry, let me just make this full screen here. Okay. Oh, I did not do that. Okay. So Arthur is our next case. He's a 64-year-old male who was admitted after being hit by a car. He suffered moderate traumatic brain injury. He's able to be extubated. He can protect his airway, but he really can't interact much with his team. He's been pretty gruff with his team. He usually says, "Go away and leave me alone." He still needs to be hospitalized. So the discussion questions now for us, what does it mean to provide spiritual care for a patient who's unable to participate in the tools that we just discussed? How might spiritual care look different for Arthur? In a patient like Arthur, how might your own spiritual practice actually affect how spiritual care is provided? And are there any special needs that we can spotlight for the staff? So I'm going to stop sharing, and Kashali, thank you for breaking us out into breakout rooms. So please push the button to say that that you accept the invitation, and we will bring you back in about 9 minutes, which puts us, as we welcome everybody back in. Just want to take a little bit of time to introduce our clinician panelist, Dr. Joshua Jordan, who I have had the pleasure of getting to know over the past few years. Thank you, Dr. Jordan, for being a panelist here. Dr. Jordan is an internal medicine hospitalist, internal medicine physician. He's also a member of our hospital ethics committee, and we share the distinction of both being married to lawyers. So we probably lose a lot of arguments. And then I want to turn it over to Dr. Barcelo. Can you introduce our chaplain panelist?
So we had selected chaplain Derek, but he might have been pulled out to a case, and so he is not back. So I do apologize for that. We had a great conversation, and we actually have another chaplain and an ethicist, so we can always select if we want to add someone else to the conversation with Dr. Jordan.
Thank you so much for being able to fill in. So, Dr. Jordan, I know that you and I had some discussion about this case. And one of the questions is that spiritual care can look very different for a patient who is not willing to engage. And so what are some of your thoughts around this? And I'm just curious to hear from your point of view.
Oh, this case, I don't know if it's fictitious, but it is very similar to a patient that I've had. Sorry, this case is very similar to a patient I've had. How I interpret your question is from the lens of whole person care, because whole person includes spiritual, obviously the physical, the body part, and then the soul, as some of the other questions talked about. And so how I process that, especially when I lead the whole person care rounds with the residents, is I teach them it's treating the other person as I want to be treated, AKA the golden rule. And so in this case, you do have the brother. The brother can give some collateral, but say the brother didn't exist. Say there's no one else. How I would approach this is I would actually sit down, even if the patient's being belligerent, and I would take time as best I could to hear from him, even if it's curse words and things like that. Eventually, something may come out such as, hey, do you like to draw? Do you like sports? Like there's some connection somewhere. And once I form that, even if it takes several visits, once I have that, then I can kind of explore more from the perspective of, hey, what do you feel about religion or whatever, the best term is to use in this conversation. And that's how I would kind of open that door, knowing that this patient technically doesn't have decision-making capacity. And how I practice, I do feel that the best care is looking at the patient as a whole, including spiritually.
Yeah, and I really love that. I think it's really important, to recognize the different forms that spiritual care can take, just like you described. I would hate for any of our clinicians to feel like they are not able to provide spiritual care to a patient who is nonverbal, perhaps, or not able to participate intellectually in the ways that other patients might be able to. There's some people have described spiritual care as taking many forms. I love the form that you've described, sitting down, getting to know the patient, trying to understand from where the patient's coming from. I also loved what you talked about in trying to get a hold of the brother. You used a word, collateral. I hear that a lot, but for those of us who are not familiar with that word, can you describe what that means?
Oh yeah, collateral is hearsay that is official. Any family or friends that knows the person, what do they know about that patient? And so that's what, when we say collateral, that's what we're referring to.
Thank you. And I think in the bioethics world, we use collateral, or we want to seek out opportunities to understand who our patient is, and what are their lived and stated values. And maybe the brother, perhaps lives out of state, but the brother can tell a story. Oh, well, 20 years ago, this happened. So you had mentioned that where did we draw these cases from? I mean, a number of these cases do end up having involvement of the clinical ethics service. And so I'm glad to know that that clinicians such as yourself are able to provide that whole and rounded care for our patients, including attending to their spiritual lives. I want to just point out there's a comment that I really like from Dr. Yishan Ma. Spiritual is not reducible to the explicitly religious. Empathic presence and listening are deeply spiritual acts. Thank you for that. Unfortunately, this brings us to 1 o'clock, and this is the end of our clinical ethics grand rounds. I want to thank everyone for attending and for participating. I hope you were in a group and you were able to perhaps make some new friends in your group and to have some stimulating discussion. Please remember to complete your evaluations, and feel free to contact us if you have questions. If you go to the Center for Christian Bioethics, a recording of this presentation will be uploaded along with the slide deck and also the resources that Dr. Barcelo mentioned, including the article from Dr. Winslow about ethical boundaries of providing spiritual care. So thank you, everybody. Really appreciate your presence today. I hope you have a blessed rest of your day. Bye.